Hello and welcome back. This is our part 3 of lecture on important devices used in obstetrics and gynecology. So our next one is Pipelle Endocurrette, and so this is mainly used. This is actually used to take biopsy from the endometrial cavity. It samples only 10% of the endometrium, but it is very effective in detecting cancers because whenever there is endometrial cancer, the cancer cells become loose and it applies actually suction. So at the end of this tube, there are a few holes there. Okay, there are a few holes, and this is at the time of speculum examination. It can be inserted through the cervical. It is inserted through the cervical canal into the endometrial cavity, and it is the suction is applied. Okay, from here it is pulled. Okay, sometimes it comes with an a syringe. Okay, so in that case it becomes more effective. Just pull the syringe and the endometrial sample, it goes into the endocurrate. Okay, same with here. It needs only a few grams of the tissue for histopathology, so we do not need a lot of tissue, but usually sample should be taken 3 times. Okay, and every time it should be rotated to sample the different parts of the endometrium. So it can be endometrial biopsy can be taken without hysteroscopy or with hysteroscopy, which we have already discussed in a separate lecture. Now, that's the role, right? It's used for endometrial biopsy or sampling. It can be used outpatient without hysteroscopy or anesthesia, but it can be used at the time of hysteroscopy, which is better. What are the indications? Indication is mainly to rule out endometrial hyperplasia and endometrial cancer. And how does the patient may present with intermenstrual bleeding, with heavy menstrual bleeding, abnormally thick endometrium on ultrasound to rule out endometrial hyperplasia and cancer. That's the main indication, and the patient may present with these different presenting complaints. Now, what are the contraindications? As always, whenever we have to do something with the uterine cavity, we have to make sure that patient is not pregnant or suspected pregnancy, or even if there is no active infection. Okay, so and it's not an active cancer either of the cervix or of the uterus. So the contraindications are pregnancy or suspected pregnancy, acute pelvic inflammatory disease, acute cervical or vaginal infections, or even so an infection in any part of the endometrial cavity. Sorry if I said cancer earlier. Please forget about that. It is used to detect cancer of the endometrium. Okay. So the next device is hysteroscope. Hysteroscope, the main difference between hysteroscope and laparoscope is hysteroscope has this irrigating channel. Like, what does it mean? So at the time of hysteroscopy, how it is performed, we need a distension medium, right? And what is a distension medium? Distension medium, it means to inflate the uterus. Okay, so that's a distension medium. Like at laparoscopy, the distension medium is carbon dioxide. At hysteroscopy, the distension medium is normal saline. Okay, so how is normal saline infused into the endometrial cavity? So it is attached through a drip of normal saline. It is attached, the tubing is attached to this irrigating channel. So that's the difference between a laparoscope and a hysteroscope. Hysteroscope has an irrigating channel, which means it is connected to a bag of normal saline. At laparoscope, that's not attached. It's just the abdomen is inflated with carbon dioxide. Okay, so a hysteroscope has two these ends, right? So this is the eyepiece, and that's the distal end. That's the objective, right? So this end of the hysteroscope, and by the way, hysteroscopes can be rigid or they can be flexible, and they may have different diameters. Like the diameter of the hysteroscope may be different. Okay, for example, in outpatient hysteroscopy, the narrow diameter hysteroscopes should be used because the patients are not given anesthesia. In the UAE, well, usually outpatient hysteroscopy usually is not performed, so it does not matter a lot here. Now, the end of the hysteroscope, it can be different angled, like it can be zero angle, or it can be, say, for example, 30 degrees. Okay, so it matters actually, but because what is the angle or at the distal end of the objective of the hysteroscope, the appearance it's different. Okay, And with hysteroscope, because we know that hysteroscopy can be diagnostic or it can be operative, right? So with this hysteroscope, other devices can be attached. Okay, for example, if someone has to do a polypectomy, for example, another device can be attached, and there are different kinds of devices. For example, MyoSure, one of the devices is MyoSure, so MyoSure can be attached to it to remove the polyp. Okay, and there are different devices; they have different names. But remember that hysteroscopy can be used for diagnostic purposes or therapeutic purposes. So, for diagnostic purposes, for example, if an ultrasound cannot detect an endometrial polyp, because transvaginal scan sometimes misses, right? So, what is the best way? Just do a hysteroscopy and see if there is an endometrial polyp, and do therapeutic at the same time. So, do diagnostic, and if there is an endometrial polyp, remove it. So, do hysteroscopic polypectomy. And the patient may present with different complaints, right? So it may be heavy menstrual bleeding or postmenopausal bleeding. But if someone asks you for indication of diagnostic hysteroscopy, you say suspected endometrial polyp. Okay. Or if we suspect that there is an endometrial uterine septum, for example, and how will the patient present? They may have repeated the miscarriages. Okay. And a patient, if not all cases of infertility, I know a lot of centers, they just do hysteroscopy as a routine part of investigation for infertility. That's the different protocols, but yes, it can be used in the diagnosis of infertility, because sometimes we don't know and there may be a septum or adhesions or some other problem. Okay, and to diagnose submucosal fibroids and polyps. Okay, now therapeutic, for example, if there is an endometrial polyp or submucosal fibroid, yes, it can be operated upon. Removal of a lost IUCD, for example, if the IUCD was impacted in the wall of the uterus and otherwise we could not remove it. If there is, this thing is called Asherman syndrome. Asherman syndrome means, for example, if the previously a woman had had a DNC, like evacuation of retained products of conception, which in most parts of the world it's called DNC, dilatation and curettage, right? So she had a miscarriage and she had this evacuation of retained products of conception, but at the time of that evacuation, the doctor over enthusiastically curated, okay, tried to clean the uterus, and which can cause damage to the endometrium. Now, once the endometrium is damaged, as a natural response, there is adhesions are formed. Okay, because that's a damaged tissue, right? So it's kind of a scar tissue. So there are adhesions between the walls of the uterus. So inside the cavity of the uterus, there will be adhesions. That thing is called Asherman syndrome that can interfere with periods. Okay, so women can have either very little bleeding or their bleeding may stop, amenorrhea. Okay, so, and of course they cannot get pregnant because it will interfere with, there is deficient endometrium, there are adhesions, so it will interfere with implantation. So what is the treatment? Then break the adhesions, perform a hysteroscopy, do adhesionolysis, and then, because the adhesions can form again, so usually an intrauterine device is left for a few months. So until and unless it is healed, and then remove it later. Okay, so that's Asherman syndrome. Now and then, if there is a, say for example, septum, then it can be removed. So, what are the contraindications? Again, if we suspect pregnancy or if there is pregnancy, of course, it's a contraindication. If there is active infection or if an active genital herpes, confirmed cervical or endometrial cancer, okay, then that's a contraindication. Okay, so um, so for biopsy, yes, of course, right? For, say, for example, in the investigation of endometrial cancer, yes, like we have to take a biopsy, right? So yes, you can take a biopsy at the time of hysteroscopy. Now, what are the complications? Now, whenever you are asked about complications of any procedure in any specialty, always think about complication related to the type of anesthesia which is given and complication related to the surgery itself. For example, if it's a general anesthesia, the patient can have nausea, vomiting, even aspiration pneumonia, which is Mendelssohn syndrome. And then related to surgery, now in surgery, there are three main complications in any kind of surgery general. Okay, first is risk of bleeding. Okay, which if there is bleeding, patient may need blood transfusion. It depends on the type of surgery and how, whether it's major or minor. Second is risk of having infection. Now, infection can be at the skin site or it can be deep, okay, like a pelvic abscess, depending on how deep it is, how big is the procedure. Then third one is trauma. Trauma to the organ itself, which is operated upon, and even to the surrounding structures. For example, if someone is operating upon uterus, we can make a hole in the uterus, and bowel is very close, right? So we can make even damage the bowel or the blood vessels or even the nerves. But specific to hysteroscopy, because we said that the distension medium is normal saline, right? And if the procedure goes very long, usually hysteroscopy is very quick, right? It's 5 to 10 minutes. But usually, if it's a operative, complicated hysteroscopy, for example, if there is resection of a septum, for example, right? It may take a lot of time, for hour or more than that, and then a little bit of this fluid, normal saline, can go into systemic circulation. So the patient may have fluid overload. When there is a lot of fluid in the patient, then what will happen? It will cause hyponatremia. Okay, with hyponatremia, what will happen if there is severe hyponatremia? Patient can have fits, right? It can be a life-threatening situation. So whenever there is operative hysteroscopy, it is important to keep a record of input and output, right? How much fluid is going into the uterus and how much is coming out. Okay, so it's very important for operative hysteroscopy. For diagnostic hysteroscopy, it does not take long. So usually input-output monitoring is not important for diagnostic hysteroscopy, but it is very important for operative hysteroscopy, especially if it is taking time. Okay, and the anesthetist should know that. Of course, if a patient all of a sudden starts to have fits or some like severe complications, that may be related to this severe hyponatremia and fluid overload. Okay, so next is laparoscopy, and I will discuss that